Hi everyone, today we're going to talk about esophageal varices, the pathophysiology, blood flow diagnosis and treatment. So what are esophageal varices? Esophageal varices are one of the most common causes of acute upper gastrointestinal bleeding worldwide. Esophageal varices are enlarged veins in the esophagus, the tube connecting the throat and the stomach that can cause a life-threatening bleeding if they rupture. The primary cause of esophageal varices is portal hypertension, a condition where blood pressure in the portal vein is abnormally high. The high pressure in the portal vein forces blood to find alternative pathways, leading to the formation of these swollen veins in the esophagus. Portal hypertension is a common complication of liver cirrhosis, a condition where liver-related diseases and conditions replace healthy liver tissue with scar tissue. This is known as fibrosis, and it impairs liver function. Liver cirrhosis is the most common cause of the esophageal varices in the Western world today. Due to the high pressure in the portal vein system, the esophageal varices' weakened walls make them prone to rupture and bleeding, which can be severe and even life-threatening. Hepatocytes, the primary functional cells of the liver, are responsible for carbohydrate, lipid, and protein metabolism, detoxification, and immune cell activation to maintain liver homeostasis. The liver receives blood from two sources: the hepatic artery, which originates from the celiac branch of the abdominal aorta and carries oxygenated blood from the circulation to the liver, and the hepatic portal vein, carrying nutrient-rich deoxygenated blood from the small intestine and spleen to the liver. Both the hepatic artery and portal vein branch into the smaller vessels, eventually leading to the sinusoids, specialized capillaries within the liver tissue where blood from both sources mixes and where hepatocytes perform their functions. Blood then flows through the sinusoids towards the central veins. The central veins converge to form the larger hepatic veins that carry the processed blood away from the liver and into the inferior vena cava, which then returns the blood to the heart. This one's just a little bit of a video to show the blood flow through the artery and the vein down past the sinusoids and into the central vein. What is portal hypertension? So portal hypertension is the abnormally high increase in the pressure within the portal vein and its branches. The high pressures in the portal vein forces blood to find an alternative pathway, leading to the formation of swollen veins in the esophagus. The development of portal hypertension is due to persistent chronic inflammation, hypoxia, and liver injury. Fibrogenesis. Liver injury activates a wound healing response termed fibrogenesis, which involves activation of the hepatic stellate cells, which are HSCs. These are specialized liver cells that at rest store vitamin A and are a key role in liver physiology and disease. In a normal, healthy patient, this response would allow a damaged liver to repair and regenerate. In liver injury, hepatocytes release inflammatory mediators such as cytokines, which primarily facilitate cellular communication in the immune system, and growth factors that are involved in cell division, proliferation, and tissue maintenance. Chronic liver injury leads to persistent HSC activation, with the HSCs changing into myofibroblasts, leading to the excessive production of collagen-rich extracellular matrix proteins. The result of this process is the accumulation of scar tissue, and in some cases, development of cirrhosis, at which point the fibrotic scarring is irreversible. Angiogenesis is a normal process in the liver for repair and regeneration, but when the liver is damaged, along with fibrogenesis, becomes a problem. Dysregulated angiogenesis leads to liver vascular remodeling, increased resistance, and portal hypertension. Despite new vessels being formed, perfusion is decreased and the overall blood flow to the hepatocytes decreases, impairing liver function. Nitric oxide plays various roles in the body, including promoting liver formation during development and in the regenerative process after liver injury by influencing cell proliferation and preventing apoptosis. In a healthy liver, nitric oxide helps to maintain hepatic blood flow and is involved in vasodilation of the blood vessels, ensuring that liver cells get enough oxygen and nutrients. While beneficial in early regeneration, excessive nitric oxide can be detrimental. When the liver is injured due to factors like alcohol, viral infections, or fatty liver, this triggers an immune response in the liver, leading to activation of iNOS, which is the inducible nitric oxide synthase, an enzyme that produces large amounts of nitric oxide. High levels of nitric oxide can be harmful, causing vasodilation in the blood vessels and systemic circulation, reducing peripheral vascular resistance leading to portal hypertension. Increased pressure in the portal vein leads to complications like varices, blood clots in the portal or splenic veins, certain liver infections, and conditions that affect blood flow both before and after the liver. The problems with the vascular blood flow in the liver can occur either prehepatic, before the liver, intrahepatic, within the liver, or posthepatic, after the liver. Causes of portal hypertension which lead to esophageal varices include cirrhosis, hepatitis, alcohol abuse, portal and splenic vein thrombosis, autoimmune diseases of the liver. It can be congenital tumours and metastases and some infections. The major cause of morbidity and mortality in cirrhotic patients is the development of portal hypertension and hyperdynamic circulation, leading to other complications like infections, ascites, accumulation of fluid in the abdominal cavity, and variceal bleeding. Liver cirrhosis is where scar tissue replaces healthy liver tissue, obstructing the blood flow. There's 4 stages of cirrhosis. Many of the stages are caused by the overindulgence in alcohol over many years, chronic infections such as hepatitis B or C, and non-alcoholic fatty liver disease or non-alcoholic steatohepatitis. Diagnosis of esophageal varices is typically diagnosed using endoscopy and treated with a combination of endoscopic procedures, medications, and sometimes surgeries to stop the bleeding. The endoscopy EGD is the primary gold standard diagnostic tool. A thin, flexible tube with a camera is inserted down the throat to visualize the esophagus and the varices. Hepatic venous pressure gradient. This measures the pressure in the portal vein, which is often elevated in cases of esophageal varices due to liver disease. This involves inserting a balloon-tipped catheter into a hepatic vein, typically via the right jugular vein, and using pressure monitor to record pressures with the balloon deflated, which is free pressure, or inflated wedged pressure. Other tests include blood tests, imaging like CTs and MRIs, and a Doppler sonography can be used to assess the extent of liver disease and portal hypertension. Treatment is via endoscopic therapy. You could do endoscopic variceal ligation, where bands are placed around the varices to stop and prevent the bleeding. Sclerotherapy, a solutions injected into the varices to make them collapse. Medications such as beta blockers and antibiotics can help lower blood pressure in the portal vein and also used to prevent and treat infections, especially in cases of bleeding. And other treatments such as balloon tamponade, a tube with balloons is inserted into the esophagus to compress the varices and stop bleeding. Transjugular intrahepatic shunt, a shunt's placed between the portal and hepatic veins to reduce the portal pressure, and surgery can be considered in severe cases where other treatments are not effective. In the pre-hospital environment, hemorrhage is the biggest thing we're concerned about. It's considered a medical emergency and must be treated immediately. In this case, the treatment's aimed at controlling the hemorrhage as well as the prevention of complications associated with the bleeding. Currently, there's no pre-hospital techniques are available to stop this internal hemorrhage. So stabilization, which includes observations, airway management, supplemental oxygen, and intravenous access. In some cases, acute esophageal variceal bleeds might need intravenous IV to improve tissue perfusion, correct intravascular hypovolemia, and stabilize blood pressure to prevent multi-organ failure. It typically presents with a severe hemorrhage characterized by frank hematemesis and or melena, severe anemia, and possible LOC. Important considerations: esophageal varices are a serious complication of liver disease, and early diagnosis and treatment are crucial for preventing life-threatening bleeding. Individuals with liver disease should be screened for esophageal varices, especially those with cirrhosis, and treatment strategies should be tailored to the individual patient's condition and the severity of the varices. Thank you.